This is the second part of my bariatric series of videos. As you can see, 5 years have elapsed since the first video, and I've in fact had successful bariatric surgery myself. Some things have changed, so I decided to put in a second video. The aim of the first video is to tell you why the whole world is fat, why the world is getting fatter, why medical weight loss hardly ever works long term, and what the surgical options are for weight loss. Basically, we talked about the operations being restrictive and malabsorptive, but that's a gross oversimplification. Basically, they work at the level of gut hormones and stretch receptors in the wall of the stomach or the small bowel. What all the operations do, some more than others, is that they decrease your appetite. People who've had weight loss surgery don't get as hungry, and they tend to forget to have meals because they weren't hungry at mealtime. But they also make it so that you eat a small amount of food and you feel satisfied by it. In other words, it's a way of enforcing a diet on you for the rest of your life, but it doesn't feel like you're dieting. The trouble with dieting is that you're continually hungry, and hungry is a fairly primal human urge. And you can be good on a diet for a week and ruin it in an afternoon or in a couple of hours on a diet, whereas if you have an operation, it makes it easy for you. Nonetheless, it is a tool to be used and not to be abused. And there are people out there that have weight loss surgery and then try and find a way around it. Indeed, there are people that have had the biliopancreatic diversion, the most radical of all of the weight loss operations, and lost 0 kilograms. And if you have a very sedentary lifestyle and you graze all day long, you have 6 meals instead of 3, or you have high-calorie snacks such as biscuits, cakes, chocolates, lollies, or high-calorie drinks, cordial, fruit juice, chocolate milk, soft drink, beer, wine or spirits, you can defeat all of these operations. And I've heard of stories of people putting Mars bars in blenders, melting ice cream in chocolate and drinking it. Obviously, some of these people have psychiatric disorders, but that doesn't alter the fact that they're obese. The operations basically only work also on hunger-based eating, and people eat for reasons other than hunger, and the surgery doesn't address these reasons. People eat because they're stressed or anxious, because they're depressed, because they're bored. One of my staff does that a lot. They eat because it's meal time, it's morning tea time, smoko, lunchtime. In other words, they eat out of habit when they're not really hungry. They may eat because they're lonely. Eating is also a social interaction for a lot of people. I've got friends that invite me out to lunch on a Friday once a month, and often I'm not able to go because I'm too busy. Basically, we go to a restaurant, have a nice meal, a few glasses of wine, and catch up with each other. The last time I went, at the table next to us was one of the law firms in town, and if you're in the legal profession, they seem to discuss a lot of business over lunch. And I'm sure politicians and corporate executives are the same. So if you're eating when you're not hungry, an operation isn't going to work nearly as well as if you're eating because you are hungry. I started out doing lap bands, and I did about 350 of those, but I no longer think it's a worthwhile operation for most people. It's got a few issues to my mind. Firstly, it's the operation that is the most difficult for people to tolerate. For the lap band to work, you're supposed to chew your food for 60 seconds before you swallow. Now, if you actually watch adults eat, they don't chew at all. They bite a mouthful of food off and they swallow it. You actually learn to eat solid food when you're between the age of 6 and 12 months before you can stand or walk. So trying to get an adult to chew food for 60 seconds is very difficult. And some patients learn and a lot don't learn. What I've found is that people with lap bands are okay with a mince, a stir fry, a casserole or a stew, but if they try and eat a steak or a chop or a dry piece of chicken or a dry prawn, it gets stuck and they vomit. Likewise, they're generally okay with toast or a cracker, but if they try and eat a thick slice of bread or a bread roll, unless they nibble at it like a mouse, the same thing happens. On the other hand, it doesn't restrict drinking unless it's real tight. So they'll have a bottle of wine instead of a meal, or they'll have the ice cream and the cheesecake instead of the salad or the sandwich. And I saw a lot of people go from eating too much healthy food to eating a whole lot of garbage after having a band. Now, having said that, all of the weight loss operations involve eating slower and chewing your food more, but the lap band's right at one extreme end of that, and I think it's got the worst quality of eating of the common operations. The second issue is that it takes a lot of adjusting to get it just right, where the patient can eat some solid food, not vomit excessively and lose weight. And it's basically trial and error to get where it's just right. So basically after a band, I get the patients back every 3 or 4 weeks, talk to them, weigh them and adjust them as appropriate. The aftercare is probably at least as important as the operation itself. That becomes onerous for both parties. The patient has to take a lot of time off work, petrol money, etc. It's even worse for the surgeon. If all 350 of my lap band patients started to come back and see me regularly, I wouldn't be able to see many new patients. What the surgeons did was that they taught some GPs how to adjust lap bands, and that ended up being one person in Townsville that you'll probably have already seen. Of course, the GPs were never quite as expert at it because they didn't put bands in the first place, nor was their judgment as expert. In other words, knowing how much to put in or take out, or when to do it, or the actual technical adjusting itself. And as a result, a lot of patients stopped attending, and as soon as they stopped attending, they'd stop losing weight. So in general, the band's got the worst weight loss of the common operations. The other problem with the band is that it's a prosthesis, and like all other prostheses, they bring problems of their own. They can break or wear out, they can become loose, they can get infected. The heart valves do, the joint replacements do, hernia meshes can, and so do the bands. They can slip, they can erode, they can leak. And at the end of the day, at 10 years, 30% of them have needed a reoperation. It's estimated the annual cost of band revision surgery in the United States is $200 million a year. So for all these reasons, I won't offer the band to most patients. The only one that I might think of offering a band to might be a 12-year-old girl. And I have, but even in that situation, I'd be reticent, and one of the reasons is that when the time comes for her to need her band replaced for some reason, like it's leaked or it's slipped or something like that, there probably won't be one on the shelf. I think the band companies will all diversify or they'll go under. My nurse and myself have both had a gastric bypass as a weight loss operation, and the reason we had a bypass is that we weren't suitable for a sleeve gastrectomy, and not everyone is. Bypass is an old operation. It's been around in one form or another for over 50 years, and as a laparoscopic operation for over 25 years. It has been considered the gold standard operation worldwide. In the United States and Europe, it was a predominant operation for a long time. Never been popular in Australia, although the numbers have increased. For example, I never saw a gastric bypass when I was doing my training. It's no longer the most popular operation, however, anywhere. It also has issues with both eating and late revisions. After a gastric bypass, you can develop an internal hernia and they can strangulate, and that's a complication that most people are worried about. One of my friends in New Zealand, who's done over 1,600, had his first death a couple of years ago, 8 years after a bypass. The patient was in another town, got abdominal pain, went up to the A&E, had a CT scan, it was misinterpreted. She got a bit better and was sent home. Her pain recurred and she died on the operating table with a whole lot of dead small bowel. Someone in Victoria has needed a small bowel transplant as a result of that operation. And if either the lap band patient or the gastric bypass patient rings you up 10 years post-operatively with severe abdominal pain, there's about a 50% chance it'll be a complication of your original operation. And more often something that won't be able to be left till the following morning. In other words, you might be up in the middle of the night operating. They also have trouble with eating, but it's not meat or bread getting stuck, it's sweets causing dumping syndrome, and both my nurse and I get dumping. There are two types of dumping, early and late. About 30% of people after a gastric bypass get some dumping syndrome. Early dumping is due to a low glucose. What happens with that is you get a very high initial glucose after eating sweets. The pancreas overreacts and you get a big surge of insulin, and then you get a hypoglycemic episode. And it's the hypo that causes the symptoms. So if I have more than about 1.5 scoops of ice cream or 5 or 6 Cool Mints, all of a sudden I'll feel funny and have to lie down. And if I take my pulse rate, I'll have a high pulse rate. Then about an hour later, I get late dumping, which means I suddenly get some lower abdominal pain and I have to run off to the toilet in a hurry. The first time I got that, I was in a shopping centre and had a chocolate thick shake, and I almost didn't make it to the public toilet. Most people who've had a gastric bypass report intermittent abdominal pain and diarrhoea. What sort of people do I refer for gastric bypass? Well, people with BMI of over 50 with bad diabetes. I think it's a more effective operation for that than a sleeve. People with large hiatus hernia, people with reflux symptoms that are poorly controlled on medical therapy, or Barrett's esophagus, which is a metaplastic change in the esophagus related to reflux. There are some people that can't have a bypass. That's anyone with Crohn's disease, and people with significant small bowel adhesions are also poor candidates. I didn't see a bypass in my training. I've been to a workshop, seen how to do them. I've made a decision not to do gastric bypass. A lot of surgery is very simple. There's an old surgical saying, see one, do one, teach one. Gastric bypass isn't one of those. It's a complicated operation with many steps and subtleties and nuances. There's a surgeon in Fresno, California that's done over 15,000, and there's another surgeon in the States that's done over 10,000. I asked the one in Fresno over 10 years ago, how many of these should you be assisted with before you do any on your own? And he said the first 30. And I said, what's the learning curve like? And he said he thought it was about 100. So after the first 100, you should speed up significantly and your complication rate should fall. And I said, how many before you're an expert? And he said about 500. The time I asked him, the most anyone had done in Australia was 160. That surgeon's now done over 1,000, and there's a group practice of 3 surgeons in Sydney who've done well over 1,000, who've got an excellent reputation. I think if I was to learn gastric bypass, I'd need to take off several months of work and go and work in a high volume unit and do a number of them. What a number of my colleagues have done is gone to a workshop, booked a few cases for their return and flown a friend in to help them do the first couple. But I don't think that's optimal. I'm now 61, I'm in the twilight of my career, I'm going to retire in a couple of years, and I'm at a point in my life where I should be doing less operations, not more operations. And I've seen surgeons take on new and complicated operations towards the end of their career and ruin their good reputation. If you have a bariatric surgeon in town doesn't do gastric bypass either, I think he thinks he can do a couple of sleeves in the same time it might take him to do one bypass, and he's waiting for one of his former registrars to come back to town and start doing them. There are a couple of surgeons in a town north of ours that do bypass surgery, but I'm not sure of their training or experience. If I see someone I think they should have a bypass, I'll send them to Brisbane or Sydney for it. The other patients I'll send for a bypass are lap bands who've had a poor weight loss and sleeves who've regained significant weight and aren't suitable for a second sleeve. I've done some biliopancreatic diversions, and I don't think it's an operation that should ever be offered to a new patient. It's the operation that causes the most weight loss and is the best for diabetes. However, a small but significant number of patients end up with severe protein malnutrition or severe vitamin deficiencies after the surgery. And all of them need to take multivitamins for the rest of their life at a minimal cost of $30 a month. If you've got patients that you can't be sure of will come back to see you for regular review or take vitamins or have regular blood tests, you shouldn't be offering that surgery. And unfortunately, I know of no way of picking which patients will come back and see me and have regular blood tests, and the fact that they're intelligent, charming, or even a colleague means absolutely nothing in that regard. So I leave the biliopancreatic diversion as an operation of last resort after several previous failed weight loss surgeries. So basically the only operation I do and offer to patients here in Townsville is sleeve gastrectomy. As you know, a normal stomach's a big bag that holds 1 litre to 1.5 litres, and after a sleeve gastrectomy it's a narrow tube that holds 100 to 150 mils. What's left behind though is still functionally normal stomach. It still produces hydrochloric acid and pepsin, it still mechanically munches up food. It's just that it's a small stomach instead of a big stomach. Most people who've had sleeve gastrectomy can eat any type of food. They can eat meat, they can eat bread, they can eat sweets. Dumping is very unusual, and I think it's got the best quality of eating of all of the common operations. Having said that, you still need to eat slower and chew your food more than you're used to. All of the weight loss patients have some patients that will tell you their tastes have changed after surgery. We don't know why that is, but the people that tell you their tastes have changed lose more weight than the ones that don't. And I've seen people go from a tea drinker to a coffee drinker, from a red wine drinker to a white wine drinker. I used to love lasagna, now I don't fancy it very much. But I think the sleeve's got the best quality of eating of the common operations. We've seen very good weight loss from it. It's got a very low late reoperation rate. It restricts drinking as well as eating in that you can only have a glass at a time, but liquids tend to go straight through, so you can have another glass very soon after, within a minute. But you can't have a big glass all at once or a whole bottle all at once. And you can drink and then eat, but you can't eat and then drink or you'll vomit. Late reoperations for complications are incredibly rare. The surgeons in Sydney have seen a number of sleeve strictures, in other words a narrowing in the mid-body of the sleeve. We haven't had any in Townsville, so I don't know what they've been doing to get them. The other bariatric surgeon in town's had a few patients where the sleeve seemed to be twisting and the patient vomiting, and he had to reoperate to suture it down onto the omentum so it couldn't twist. I haven't had one of those either. If the sleeve patient rings you up 10 years post-op with abdominal pain, it is never the sleeve. The only common long-term problem with sleeve gastrectomy is vitamin B12 deficiency. Vitamin B12 is absorbed by the end of the small bowel, but it needs to bind to intrinsic factor on the wall of the stomach on the way down. And if you've removed most of it, as you have with a sleeve, or if you bypass it, as in the case of a gastric bypass, you can develop vitamin B12 deficiency. It either happens or it doesn't, and I think it happens between 5 and 15% of people after a sleeve gastrectomy. If it happens, taking vitamin B12 tablets doesn't help because it's an absorption problem, not a supply problem. And you need vitamin B12 injections usually every 3 months. All 3 bovies who've had weight loss surgery, in other words myself and 2 of my sisters, are B12 deficient, 2 after bypass and 1 after a sleeve. The B12 is stored in the liver, and if you've got big stores it can take quite a long time before you become deficient. One of my sisters and myself developed vitamin B12 deficiency in the first 12 months, but the other one took almost 4 years to become deficient. For that reason, I do blood tests every 6 months on the weight loss patients, up to about 3 or 4 years. If after 3 or 4 years you haven't developed vitamin B12 deficiency, you won't develop it. I've had patients who've only needed 1 vitamin B12 injection and have then been able to maintain it. From my own perspective, it's easier to have a 3-monthly injection than to have a 3-monthly blood test. There is a sublingual spray which may help some patients to avoid injections, and I've seen vitamin B12 tablets with intrinsic factor in them overseas, but they're not available in our country. It is important to diagnose the B12 deficiency. Most people are asymptomatic, but B12 is not only needed by tissue that makes red blood cells, but also by neural tissue. And you can get visual disturbance and you can get spinal cord damage from severe B12 deficiency. There's someone from Townsville who went down to the Gold Coast and had a sleeve with no follow-up, now has trouble walking as a result of subacute combined degeneration of the spinal cord. And if you get that, replacing the B12 may not improve the syndrome. The other concern we have with sleeve gastrectomy is developing new reflux. And I haven't seen that as a big problem in my practice, but other surgeons have, and I'll talk about that a little bit later. There are two negative things to say about the sleeve. Firstly, it's the newest of the common weight loss operations, and as a result, we've got the least long-term follow-up data for it. The other operations are all a lot older. The lap band's over 20, the gastric bypass is over 25 as a laparoscopic operation. The biliopancreatic diversion's over 30, but the sleeve's only about 12 or 13. And I've seen good data out to about 6 or 7 years, but the data beyond that's fairly sketchy. And if you were to ask me what is the 10-year weight loss data for sleeve gastrectomy, I don't think I can really tell you. I've seen some papers, but the numbers were small. And when you consider that 18,000 sleeves were done last year in Australia and 100,000 in the United States, a paper where they had 20 patients at 10 years becomes fairly meaningless. All of the operations have some patients with a disappointing initial weight loss. In other words, they've had a poor result from the operation. And all of the operations have patients with a good initial weight loss and then significant weight regain. And we're talking about figures between 15 and 25% of people with significant weight regain after all of the operations. This can happen for one or two reasons. Firstly, the patient can learn bad behaviours. In other words, they have 6 meals a day instead of 3, they start having high energy snacks or liquids. I had a girl come back to see me who'd regained 7 kilograms in 3 months. And when we investigated it, she had an 80 ml stomach. And I said to her, it's not the operation, it's you. And I don't know whether she needed a divorce, a new job, a holiday, to get rid of her kids, or happy pills, but it wasn't another operation. And I think she was having a lot of Coca-Cola. If the patient says that they're hungry all the time, maybe they need a different operation. But if they're eating because they're stressed, depressed, bored, or for social reasons, well, another operation isn't going to help them at all, and perhaps they should be looking at medical therapy. There are 2 drugs called Quizemia and Contrave available in the United States, but I don't believe are available in this country. And in Australia, there's Saxenda, which is a once daily injection that decreases your appetite. On the downside, it costs $387 a month. But it can be effective, and I've seen people lose 10, 12 kilograms on it. From my own patients, I've done about 830 sleeves. I've done 7 re-sleeves for weight regain. I've sent about 15 to 20 patients off to have their sleeve turned into a gastric bypass. I've got 2 patients that today weigh more than they did prior to their sleeve. One of those had a very good initial weight loss, then had an unsuccessful back operation and is now in a wheelchair and has chronic pain and is severely depressed. Some of the medication she's been put on probably caused her to regain all of her weight. The other one's a woman that had a lap band first, had a fairly poor weight loss, had the band out, regained all the weight, had a sleeve as a second operation, had a fairly poor weight loss and slowly regained all the weight. I don't think a sleeve's an appropriate re-intervention after a lap band with failed weight loss. I think it can be good after a lap band with successful weight loss and then a complication. But I think she'd have been better to have had a gastric bypass. I've had a few other patients, 4 or 5, who've regained about half of their lost weight and haven't had a re-operation for various reasons. One of those has PTSD due to workplace bullying and is drinking a lot of Coca-Cola. Another one has become demented. Another one only had the operation so he could have a hip replacement, and he's had it, and he's not interested in losing any more weight. But I'm not seeing a lot of patients come back with weight regain. Having said that, I've seen a lot of fairly poor quality sleeves on YouTube where I'm sure some of those surgeons will have a lot of patients come back. We do know the bigger the patient, the smaller you need to make the bougie to have an adequate weight loss. We know the bigger you make it, the more likely it is to stretch. The other reason for weight regain, of course, is that the body adapts to attempts to make it thin. And in the case of the sleeve will stretch. In the case of a gastric bypass, the gastric pouch can stretch. The anastomosis between the pouch and the small bowel can stretch. The small bowel can stretch and take over a stomach-like function. In the biliopancreatic diversion, the common channel of small bowel can lengthen and widen. And if those things happen, there may be a surgical solution. Now, the stomach will stretch in everyone after a sleeve, but in most people stretch is just enough so that after the first 9 to 12 months they find eating a bit easier, they can eat a bit more and their weight loss plateaus, or they might regain 1 or 2 kilograms. And just because the stomach has stretched, sometimes even significantly, doesn't mean there'll be any weight regain at all. One of my most successful patients is a local Townsville solicitor who lost over 70 kilograms. He came back to see me about 5 years post-op with abdominal pain, and in the course of investigation we got a CT scan which showed the pain was due to kidney stones. But what surprised me was how big the stomach had stretched, and yet he was still thin, and as far as I know he still is. Why does the stomach stretch? Well, in some cases you've made the sleeve too big to start off with. There's a lot of variation in bougie sizes, how much antrum people leave intact, how close they get to the esophagus at the top end. If you go too far from the esophagus, you can leave a fundal pouch, it's likely to stretch. But even in the one surgeon, even on the one operating list, none of the sleeves are going to be the same. And I might have 4 sleeves on the list and try and do the same operation 4 times, but I'll have 4 different sized stomachs, and I might think one's perfect, one's good, another one's good, and one was difficult. The one that was difficult is going to be bigger than the one that I thought was perfect. To that end, we do ask people to lose weight pre-operatively by going on a very low calorie total meal replacement shake. And we know that if you do and you stick to the instructions, weight loss is inevitable. The first part of the body to lose weight is the liver. So if the liver shrinks, the operation becomes easier and consequently safer, but you also get a better quality operation out of it. I think you get a smaller stomach. It's easier to see where the edge of the stomach is, etc. Some people habitually overeat. And if you have an extra mouthful of food every time you eat, that might make the sleeve stretch. Now, having said that, satiety cues can be different after a sleeve. Now, a lot of people will just realise that they've eaten enough or they've eaten too much, they'll get uncomfortable. But I've had people that would suddenly get pain in an ear or would sneeze, or their nose would start running, or their eye would start watering as a sign that they were full. Some stomachs are probably just genetically predisposed to stretch more than others. So what do we do if you've either had a poor weight loss initially or you've had significant weight regain? Obviously we get you back, we send you back to see the dietitian, we might do a food diary. I'll get you to eat creamed rice on an empty stomach and weigh the tin before and afterwards, and that gives us an idea of the functional volume of the stomach. And if that's large, then we'll get an X-ray of the stomach to assess its size and shape. And the X-ray is called a phys-CT. It's a CT scan done on an empty stomach after giving you sherbet, which causes the stomach to become distended with gas. Now, if the stomach's stretched enough, sometimes you can do a second sleeve, and I've done 7 of those so far. It needs to have stretched a fair bit. You want to be able to remove a decent amount of tissue to think that you're going to make a difference. You don't want to be just inside the old staple line. You can't use the stapler to crimp the stomach. And it has to have stretched reasonably symmetrically, and sometimes the staple line's very spiral and it doesn't look like you could safely do a re-sleeve. I'll only do the re-sleeve for weight regain. I'll tell the patient it's my aim to get them back to the lowest weight they were after their initial operation. I think if you think they're going to be lighter than that, you're kidding yourself. We do know it's much higher risk of a significant or serious complication like a leak than a sleeve on a normal stomach. There's very little data available. So far I've done 7. 2 have done very well. One's a total failure and the others it's too early to say, and it's my impression that an occasional patient will do very well and a number of them will be fairly disappointed by the result. Often the stomach just hasn't stretched enough, or the staple lines such that you don't think you can easily remove it doing a re-sleeve. What I did initially with those patients was pleated the stomach with sutures, and I can tell you that that doesn't work. It didn't cause permanent weight loss, just temporary weight loss. You can put a lap band around a sleeve. It's fairly easy to do. There's a surgeon in the States that does that to every sleeve he does. There's a surgeon in Belgium who puts elastic rings around the top of his sleeves. A friend of mine in Perth does the same. They're doing that to try and prevent weight regain, although my friend in Perth said he got 10% better weight loss with the silastic ring. I put one silastic ring on, and I've put 4 lap bands on sleeves subsequently for weight regain. The silastic ring I put on was at a patient request at the time. It didn't prevent weight regain in her. She gained 8 kilograms last year. The 4 that had a lap band put on, 3 had had a lap band first, had had a very successful weight loss with it, then had to have it out for a complication. They regained weight, had a sleeve, initially did well, then started to gain weight, and they all said to me, I used to like my band, it suited me, can you put a band back on the sleeve? The 4th one, I'd done bands on 2 of her daughters when they were 13 and 15, and when she had weight regain, she said, can you put a band on the sleeve and I'll come along with my girls and you can do all of our adjustments at the same time. All 4 of them had a wonderful weight loss and ended up in the normal weight range, but one of them then came back 5 years later having regained 9 kilograms, and when we investigated it, her band was eroding her sleeve. Now, band eroding a normal stomach's not uncommon and usually fairly easily dealt with, but band eroding a sleeve I thought was a major problem. I sent it to my friend in Brisbane who's keen to tackle challenging cases. His gastroenterologist was actually able to remove the eroded band endoscopically after we'd failed in Townsville, and he subsequently did a difficult and, dare I say it, very risky gastric bypass on her. And that's put me off doing any more of those. You can turn a sleeve into a Roux-en-Y gastric bypass fairly readily if you look at the diagram, and I've sent between 15 and 20 patients off for that. It's usually not technically difficult to do, but sometimes the added weight loss is modest. You can turn it into a simpler version of a gastric bypass called an omega loop single anastomosis gastric bypass, or mini gastric bypass, which are 3 names for one operation, as per this diagram. This is a somewhat controversial operation. It was invented by an American surgeon, and in his own country he's been very polarising, and I think that's due to his personality, which might be likened to the president. In the States, that operation's not recognised as a bona fide weight loss operation, it's not covered by any private health insurance companies. However, many of them have been done in Europe, in India, in Korea, by surgeons that everyone respects who seem to be able to reproduce the same excellent results. I've been to a workshop, I've seen how to do it. I think it's an operation we should be able to offer in Townsville. It's a much simpler operation, but it does incorporate some degree of bypass. Patients on it do definitely need to take vitamin supplements, and particularly calcium and iron, as well as vitamins. I'm going to start offering it to sleeves that have regained weight, that aren't suitable for a re-sleeve, don't want to go to Brisbane or Sydney to have a gastric bypass. Now, I might do 1 or 2 and decide I don't like it, or I might do 3 or 4 and decide it's a wonderful operation and start offering it to everyone, but it's not the case at the moment. The other option is to turn a sleeve into an operation called a SADS or SIPS operation, which is a variety of biliopancreatic diversion, where 2.5 to 3 metre limb of small bowel is anastomosed onto the duodenum. It's allegedly much safer in terms of the risk of malnutrition than a conventional biliopancreatic diversion. I've got an open mind about this operation. I may well learn how to do it, but we shall have to see. Certainly there are a number of surgeons in the States that are keen on it. Or you can turn a sleeve into a conventional duodenal switch version of biliopancreatic diversion, and I'm not going to offer that to anyone except as a last resort operation for the reasons already mentioned. I think of all of these reoperations for weight regain after a sleeve, the only one that's made more problematic by having the sleeve in the first place is the re-sleeve. Whereas I think if you've had a lap band, it's difficult to do a nice sleeve, and it's not very easy, for that matter, I think, to do a gastric bypass either. The surgeons say that it's easy and the results are good, but I've watched them struggle through them a number of times. If you were to ask me in 10 years' time, will you still be doing sleeve gastrectomy? The answer is no. I'll be retired by some personal unforeseen financial disaster. But I think it'll still be a popular operation. If not, why not? Well, there are those that say that a lot of patients will get reflux and get Barrett's esophagus and the sleeve will be abandoned, but I'm not seeing that at all in my practice. I think if it's not popular in 10 years, it might be because someone's come up with a better operation, or there's a cheap and effective weight loss tablet's been developed. Certainly I've seen a gastric clamp which has been put in patients in a clinical trial in the United States that looks promising. It reproduces a sleeve gastrectomy, but it's removable, and it's a simple device that doesn't involve dividing a lot of blood vessels. I might say though that when I last saw a presentation 2 years ago, the surgeon had done 67 of them, and as of last month he'd done 67 of them, so he doesn't seem to be going anywhere with it. But if I saw a 12-year-old, I might say to them, let's wait and see if Zundel's gastric clamp is available, rather than do an operation like a sleeve, which is not reversible. On the other hand, if you'd asked me 10 years ago, in 10 years' time, would you still be doing lap bands? The answer would be no. I could see the writing on the wall very early on. The other thing to say about the sleeve is it's a big operation up front and it's not without risk. There's a small but definite risk just getting the anaesthetic without the operation itself. The specific risks from sleeve gastrectomy are bleeding and leakage. When you're doing a sleeve, you're dividing between 20 and 40 small arteries and their associated veins, and you're reliant on the modern technology to seal and divide the vessels for you. It's not as if you're clamping, cutting them and tying them like we used to do with open surgery. Having said that, just because you've clamped, cut and tied off a vessel doesn't guarantee it won't bleed either. The average blood loss during a sleeve gastrectomy would be less than 5 mils, but I've had 9 patients that lost more than 200 mils. I was able to stop the bleeding in 8 out of 9 times laparoscopically by pressing on the bleeder, putting another instrument through a new port, putting a clip on it, diatherming it or using an energy source on it. The remaining one I couldn't stop bleeding. We ended up having to make a big incision and suturing the bleeder. The most blood I lost without having to open someone up was 1800 mils. My colleague in Townsville put a hole in a splenic vein doing a sleeve on a big man, lost 3 litres of blood, had to open the patient and take the spleen out during a sleeve gastrectomy. You can have post-operative bleeding. Obviously it's dry at the end of the operation, but sometimes people start to bleed in recovery or up in the ward. I've seen 4 orderlies trying to hold someone down in recovery who was confused and combative as he was waking up. Or you might cough or vomit, that might be enough to dislodge a clot. Usually if that happens, it's a single vessel. Usually they'll stop on their own. In the first 5 years, about once a year I'd need to give one of the sleeves a unit or two of blood, and I had to take 6 back to theatre for post-op bleeding because the bleeding didn't stop or they were bleeding quickly. Every time that happened, by the time we got back to theatre, the bleeding had already stopped. All I ended up doing was sucking out the blood. But one of them had 6 litres of blood in the abdomen, so if you told me you were a Jehovah's Witness, we'd have a difficult conversation about that. I use 2 products to try and prevent bleeding. One of them is called SeamGuard. It's an absorbable fabric that the staples go through, so it's like a buttress material. The other one is Tisseal Fibrin Sealant, commonly referred to as Tisseal Glue. That looks like a 2-part epoxy, like Araldite. It's made from human blood. It's got 2 syringes. One's got fibrinogen in it, one's got thrombin in it. They mix at the end of a nozzle and become fibrin, the matrix of a blood clot. It actually looks a bit like white paper glue, like Clag, and that's sprayed all over the staple line. Some surgeons don't use either of those. The main problem isn't bleeding, it's having a hole form in the staple line and gastric juice leak out. When you're operating on the gut, whether it's the esophagus, stomach, duodenum, small bowel, large bowel, rectum, if you've got a suture line, staple line or a joint of any type, there's a risk of it leaking. It's hardly ever a mechanical issue. It's not as if the stapler's misfired, the sutures are too far apart, etc. It's usually a healing issue. One spot, instead of healing, normally breaks down and forms a hole. And you might be the best person in the world at esophageal cancer surgery or rectal cancer surgery, you're still going to have a leak rate. Leak rates are surgeon and hospital dependent. The bad parts for leaks are the esophagus, the duodenum and the lower half of the rectum. The stomach's got the lowest leak rate in the gut. I've read of leak rates for sleeves anywhere between 0.5% and 7%. I know of surgeons that have done 800 cases without a leak. I think most people would say leak rates after sleeves are falling continually, and the expected leak rate today is somewhere between 0.2% and 0.5%. I've only had to reoperate on one patient for a leak in the last 5 years, and that was over 2 years ago. She spent about 4 weeks in hospital over a 6-week period. She's now perfectly well and has lost 40 kilograms. I've also had 2 very small leaks that didn't require further surgery but did need an endoscopy and some IV antibiotics. We know that nearly all leaks occur at the top end of the staple line. It's the thinnest part of the stomach with the poorest blood supply. It's also got the lowest burst pressure. We think that if you get too near the esophagus at the top end, you're more likely to have a leak, so we veer out about 1 centimetre from the top. We know that the smaller the bougie, the higher the risk of having a leak. Conversely, the bigger the bougie, the less weight loss and the more likely to have weight regain. I believe, and most surgeons believe, that buttress materials like SeamGuard decrease the risk of leaking. It's been shown that if you bury the top of the staple line with sutures, it's less likely to leak, and I do that as well. Tisseal glue may also lower the leak rate. It's not been studied. Colorectal surgeons believe it decreases the risk of leaks from anterior resections of a rectum, for example. There are 2 clinical sorts of leaks, early and late. The early leak can also become chronic. An early leak occurs within the first post-op week, usually before the patient's gone home. Basically, they have peritonitis and they behave clinically like a perforated peptic ulcer. They'll either seem fine and suddenly get pain, or they'll have more pain than expected that gets worse rather than better. Often they'll have a high pulse rate. If you do a CT scan, you might see fluid and gas outside the stomach. You take these patients back to theatre, do a laparoscopy, suck all the gastric juice out, wash it out, put a drain in, and you repair the hole if possible. The late leak occurs after they've gone home, and it's not really a late leak, it's a delayed presentation of an early leak. The stomach either heals or it doesn't. With a late leak, they've had a small self-contained early leak with no or minimal symptoms, and then for some reason, weeks or months later, it suddenly gives way. They don't get peritonitis, they form an abscess next to the staple line because everything's all stuck up. They'll usually present with left shoulder tip pain, left lateral chest pain, left upper abdominal pain, but they may have vague or flu-like symptoms or just unexplained fever. and I've seen someone with no symptoms whatsoever. My colleague has had one at 6 months, two at 12 months and one at 14 months. He told me that the two at 12 months, one had had vague symptoms from 3 months onwards. The other one fell over and ruptured her spleen and somehow got a leak. Now I can understand how you can fall over and rupture your spleen, but I don't know how that can cause a leak. The one at 4 months he thought leaked because they were vomiting because they had a stone in their bile duct and they were sick with that. He doesn't get preoperative ultrasounds. I've had one leak on day 8, one leak on day 14, one leak on day 16, one leak at about 3.5 weeks. And the one with no symptoms at all was diagnosed at 8 weeks. Her complaint was she couldn't eat much solid food. She had no other symptoms, no pain, no nausea, normal white cell count, normal inflammatory markers. So I got an endoscopy, and I've often found people that complain they can't eat solids, as soon as you do an endoscopy, they're improved, I think just from stretching the stomach with gas. And at endoscopy, she had a small hole at the top of the staple line with a little sinus beyond it. We didn't do anything about that. I just told her we'd repeat the endoscopy in 6 months to see if it had healed, and I think we'd forgotten when that point came round. I'm sure there are probably others of those about. The late leak is managed differently. We'll get the radiologist to drain any abscess that's drainable in the X-ray department under CT or ultrasound controlled under local anaesthetic and some sedation. I'll get the gastroenterologist to do an endoscopy, and if a leak is confirmed, I'll get them to inject Botox into the pylorus, which paralyses it. That means it opens and stays open for 3 months. That lowers the pressure inside the stomach, and it means more of what's swallowed, including saliva, goes through rather than coming out the hole. If they can see a large hole, they can try and close it with a special metal clip called an Avesco clip. We've had no experience of that in Townsville. I've had 2 cases where there was a small abscess cavity draining pus into the lumen of the stomach through the hole, and I got them to put a little double pigtail drain through that. That allowed the abscess cavity to drain and collapse, and then the drain could be removed with an endoscope. Or they can put in what's called a coated wall stent, which is like a giant coronary artery stent. That's a self-expanding metal tube with a plastic membrane, and if that's deployed at the level of the leak, expands up against the wall of the esophagus and the stomach, sealing the hole from the inside but enabling you to drink. If that's then left in for 4, 6 or 8 weeks, usually the leak's healed and you're able to remove the stent. But a leak can become chronic. 50% of early leaks that are repaired then become a chronic leak. And a leak can be a serious or life-threatening condition. It usually becomes serious or life-threatening if it's not diagnosed promptly and the patient gets septic. But they can be quite hard to diagnose, and some patients get septic quite quickly. Nobody has died in Townsville from a leak. I'm sure between us we've done well over 1,700 patients. Someone from Townsville went down to Melbourne and had an operation and died. But we believe they had a bypass and died from a hemorrhage, but we weren't able to find out the details. We have, however, had patients sick in ICU, but not, I think, for several years. One of my colleagues in Perth who's done about 1,700's had 1 death. A colleague in Rocky who's done 1,250. When I last spoke to him has had 1 death, and my friend in Brisbane did my operation, and my nurses and my sisters, his tent sleeve died from a leak and it put him off doing them for a couple of years, but he's now done more than 1,000. I like the operation. I think it's got an excellent quality of eating. It's got very good weight loss, and you don't need to get the patients back frequently for a review. I see them about 10 days post-op, then at 6 weeks as part of normal aftercare. Then I see them 3 monthly for the first 12 months, then 6 monthly for the next 10 once a year, primarily to see what weight loss results I'm getting with my sleeve gastrectomies, in other words, for my benefit. I might tell them, go back and see the dietitian, stop drinking Coca-Cola, join a gym, buy a pedometer. But I can do that with lap band patients, and it doesn't cause weight loss. I'll recommend a sleeve to most patients. The ones that I'm a bit iffy with are people that have significant reflux or have hiatus hernias on endoscopy. It's been my experience that if one repairs the hiatus at the time of doing a sleeve gastrectomy. Most patients find their reflux is improved or disappears after surgery. I will ask you at your preoperative consultation if you get reflux, and if anyone is on treatment for reflux or has had a hiatus hernia seen on endoscopy, or I see a hiatus hernia at the time of doing a sleeve gastrectomy, I'll repair the hiatus hernia. It is possible to develop reflux after a sleeve gastrectomy, but in my practice that hasn't been a common occurrence, and if that happens there are things that we can do about it. If your BMI is over 35, we would like you to go on a very low calorie total meal replacement shake for 2 to 4 weeks preoperatively. If you do and you follow the instructions, weight loss is inevitable. Clinical studies with gastric bypass have shown that if you can get the patients to lose 5% of their total weight, they have fewer complications, they spend fewer minutes on the operating table, and there's also a trend towards better overall weight loss. This particularly applies to the big men more than the big women, because in big men a lot of the fat is in fact visceral. I look forward to seeing you again prior to surgery. Thank you for listening.